So that's how you would begin to make a choice about how to get somebody to treat your diabetes. Is now there's public reporting, and actually 16 out of the 17 communities in Aligning Forces for Quality have issued at least one public report, not just about hospitals, which you can get from Hospital Compare, but about individual physician practices, generally at the small group level. So how would you find out the best place to live? And of course, anybody who's been following the news for over the last couple of weeks know that the county health rankings, of course, is a good place to start. These and other kinds of reports can help you make those kinds of decisions. But if you're in a community and you want to know, well, how good is the health department? Well, how do you find that out? Do you go to Google? Well, good luck with that. Amazon Consumer Reports? No? Well, maybe one of the things that you can do is to suggest that maybe there should be some sort of public reporting about how well health departments are performing. Now, the interesting thing is that when we started doing public reporting around physicians, the first thing we heard was, well, you know, of course, public reporting is fine, but my patients are different. You know, the measures aren't really scientifically based. I have some doubts about those measures. And, you know, if you start publishing these things, I'm going to lose my patients. Well, a few years back, we talked about publicly reporting on health departments. And we started talking about things, you know, like this, and what were the responses? Well, you know, I work in a rural area. My population is different. You know, these measures aren't really, you know, validly tested, and of course, that's why I'm saying that here at this Conference on Public Health Systems and Services Research. I'll get back to that. And if you start reporting these things publicly and they see how well my health department is doing, I might lose my job. So many of the same obstacles. But I think that one of the ways that you can make a determination about a health department is to look for a seal of approval. So what does a seal of approval look like? Well, we don't have one of these for our health departments, but maybe there might be one that will be able to help us make that decision. And that's where accreditation comes in. We at the Robert Wood Johnson Foundation believe so strongly in accreditation that we have a goal. It's part of the reason why we're helping to fund this in partnership with the Centers for Disease Control. And our goal is that by 2015, 60% of the population will be covered by an accredited health department. This is what we call a stretch goal. This is a goal that we share with our board of directors, and we'll be measured on progress. Of course, that's Jim Mark's team, so it's okay for it to be a big, hairy, audacious goal. So what is accreditation? And as you know, FAB is out there, and you can begin to see their booth, but it's a measurement of health department performance against a set of nationally recognized, practice-focused, and evidence-based standards. It's the issuance of a recognition of achievement of accreditation with a specified time and frame by a nationally recognized entity. And this continual development, revision, and distribution of public health standards. It's tying standards to measurement and reporting progress. It's all the elements of putting public health out where it needs to be held accountable to the populations. So the goal of this voluntary national accreditation program is to improve and protect the health of the public by advancing the quality in territorial public health departments in state, local, and territorial health departments. So what are these standards and measures? Well, if you look at them, you know, you'll see the 10 essential public health services reflected in these measures. But here is a place for public health services and systems research to play a critical role. We're seeing a transformation occur in healthcare, and part of that reason is because there's a 20-year history of developing performance measurements, validating those measurements, testing them in the field, and then rolling them into things like pay for performance and other kinds of ways to manage quality. We need to do that same sort of rigor and apply that rigor and roll that in a continuous quality improvement loop into our accreditation process. And researchers in public health systems and services are the critical players to ensure that that system can work. So what are the things that should measure? How valid are they? Are we measuring the right stuff as part of accreditation? Are there other things that ought to be rolled in that can tell a community how well their health department is doing? These are all research issues that need to be addressed. So I started out talking a little bit about cost and the cost of health care. And that the cost of health care is a driver of much of our national policy related to quality, and to health care. And then where does that cost come from? Well, there have been some various studies that we as a foundation have funded. One was Paul Ginsberg did one recently. He did a synthesis on the issue of what is driving costs. Healthcare technology represents anywhere from roughly 40 to 65% of what drives costs. And that's because you can think about healthcare technologies doing two things. One, it adds additional treatments where there weren't treatments before. And one of the ways you can think about that is, I don't know if you were around, but when I was state health director, we had a program, the AIDS Drug Assistance Program. And I can remember the year, it was a $3 million program. Multiple drug therapy hit the scene, and within 6 months, that program was $10 million in debt. I was the one who had to sit in front of the Appropriation Committee and try to explain that one. It was not a pleasant event. But that's an example of new technology leading to cost because it's adding to the treatment. Now, there's value there because certainly we've seen us get closer and closer to HIV being seen as a chronic disease as opposed to a death sentence. Other ways that technology have an impact is by replacement. So if you were someone who had a serious knee problem 15 or 20 years ago, then what would you do? You would be taking medications, which, they aren't cheap, but they're not as expensive as getting a total knee replacement. And total knee replacements, new technology, have now had a significant impact. Now, the problem with trying to address technology is that once you start talking about blunting the effect of technology on rising costs, you begin to bring in that R word that we all have a difficult with, the rationing word. Who decides who gets and doesn't get access to this technology? Obesity counts for roughly 12%. We know about the rising tide of childhood obesity. Changing demographics, particularly the aging of America, surprisingly has little impact. And most of the reason for that is because most of the effects have already been rolled into the base in healthcare costs. The fact that we've seen rising numbers of individuals with chronic disease has already been factored into what the base is in healthcare. So we're not going to see much of a change there. That's going to continue to have an impact. It's going to have an impact on the workforce. And malpractice costs have not been a significant factor.